All right, everyone all set? So we're going to continue with a distinguished panel. We've introduced previously Dr. Eleanor Wadenobi and Dr. Nomi Levy-Carrick, both experts in trauma-informed care, international violence against women. All right, so our panel is called Sexual Trauma in Midlife, Women's Health, Consequences and Management. You've met our panelists already, and these are their disclosures. So today what we'd like to do is to identify common midlife and menopausal presentations that may be linked to sexual trauma histories, to apply trauma-informed communication and examination techniques in routine menopause care visits, and I will chime in about that since I do gynecologic care as well, and how to implement at least one concrete clinical behavioral change and one advocacy action to improve care for midlife women with sexual trauma histories. So we'll just get started, and that's our overarching goals, and we also really would like to hear from you and be able to discuss whatever questions come up. Okay, so we've already talked about this, Dr. Levy-Carrick. What's the importance of changing our narrative from asking what's wrong with this patient to what happened to this patient? Can you give us can you discuss that a little more fully?
Sure. This kind of problem-based understanding of individuals as opposed to a kind of more holistic one, I think is captured by this shift in this trauma-informed frame. So we recognize that the person we're seeing in front of us is the sort of sum total of their intergenerational histories and also their life up until that time. And the more that we can understand about what happened and the way that impacted their health, the more we can conceptualize their kind of health and well-being in ways that we can intervene more effectively.
And Dr. Wadenobi, what would you say about this internationally? Is this something that people discuss as well in terms of addressing women and girls who may have been traumatized, or how we think of that? What's a more enlightened way for our colleagues and ourselves to respond to this?
In the exact same way, not posing the question to the patient or client as to, what is wrong with you, but what are the circumstances surrounding your being here. And because it's a more community-oriented culture, by the time you pose questions, I explained earlier how there's a premium put on marriage. So, how is the family? Using nuanced language, a word that is still taboo, for example, in some cultures is, sex or sexuality education. But people will talk more about family life education. So, do you have any children? How many do you have? And that way, you begin to find out more about the patient as opposed to, what's wrong with you.
And what are some clues that you both look for? I know you discussed it in your individual talks, but for midlife or menopause woman, first I'll ask you, Dr. Wadenobi, internationally and in Africa and so forth, are there certain clues that you would have clinically that perhaps a woman is experiencing violence in some way, or there's current and then past?
Yes. Some clues are very, overt. Some are covert. When you remember that there are economic aspects to violence. So a woman who is being abused or violated is less likely to want to report it because staying in that relationship might be her only sustenance. And, you know, she doesn't want to let go of that. And yet she's carrying pain. She's going through what we would call midlife crises. Last year I explained that life expectancy at 57, when you talk of midlife, is it's in a different context. But, you know, some of the things that people will say, and they'll say it guardedly, is that, and I gave that in my presentation, "Doctor, I'm not happy. My husband wants to marry another wife." And then she begins to tell you about the menopausal symptoms that she's going through. Or she might guardedly tell you that she's a survivor of a conflict. Another big one is that she's been genitally mutilated, and she has had to have a generous episiotomy to deliver her baby. We also know what happens with early marriage. Sorry, my answer is a bit lengthy, but there are so many ramifications. A girl who is married early means that she gets pregnant before her pelvis is ready for the baby. It also means that she can have delayed, obstructed labor, and she may then suffer the deleterious effects of vesico-vaginal fistulae. So it just shows you that they can present with different ways linked to the cultural harms that they may have suffered.
And thank you. And Dr. Levy-Carrick, you walked us through the principles of trauma-informed care. Thank you for doing that. And if a clinician remembers only 3 little micro behaviors from that as they're getting used to dealing with this in their standard 15-minute visits, what things should we actually start doing next week? How would you advise us to get started in this if we're not already familiar?
So one, I think, is context. You want to frame the visit at the beginning. Say, remember to say who you are and what's going to happen, but what do you plan to do in that visit? Because that helps the patient also understand what is and also what isn't happening. And I think that making sure that that expectation is aligned right at the beginning sort of ticks a lot of those principles off. That's one. Another is being really clear that they can share as much or as little as they're comfortable with, and you will do as much or as little of the exam as they're able to tolerate that day. At the front end, saying, we'll see what you can get through, and it's no problem for you to ask me to pause. Depending on the patient in front of you, and this is the sort of the clinical art, sometimes it's actually they can't speak when they're that upset, right? So you could say, if you pick your arm up, just pick your hand up and I'll know that we have to pause. Or we can stop at any time. And then the third thing would be just checking in about what would make the visit more comfortable for them. Because, for some people, they want to know exactly what you're doing before you do it. They want to go, they want that narrative. Some people really want to put their headphones on and just distract themselves until it's done. And again, you can't know unless you ask. And for the ones who just want to be distracted, the fact that you keep talking to them is actually quite unhelpful. But most people want to know what you're going to do before you do it. But it's really, the fact that you've asked is really helpful. So I think those are, I don't know how micro they are, but those are 3.
All right. If people feel comfortable, if you would either put in the chat or turn to the person next to you, and what are a few things that resonate with you that maybe you can incorporate in your practice or advise people about? We'll just spend 2 or 3 minutes on that. Okay. Thank you so much for sharing. Again, Dr. Levy-Carrick, you talked to us about asking briefly about trauma and maybe normalizing it if that's something that's helpful. This is a potential question to ask and see if you agree with it. But because experiences like unwanted sexual contact are common and can affect menopause and sexual health, I ask all my patients, has anything like that ever happened to you that you'd like me to know about? So this could be intrusive and not appropriate, or it could be maybe, depending on your relationship and the context of the visit. But do you have any advice for us about this specifically?
Yeah, I mean, I think this is a helpful way. As you say, it sort of depends on where you are in terms of your knowledge of the patient, your contact. I do think that the first question can even just be say that people often have experiences in their life that they feel may be impacting their health. Have you had any experiences like that? And that's a sort of first round. And then the sort of second one could be, exactly this kind of language. I ask all my patients about any unwanted sexual contact. I think the one thing I would say is that it's not just sexual abuse that manifests with fear and with trauma. And so the sexual contact is important, particularly in the context of certain exams. But any kind of abuse can actually end up having this sort of sequelae for folks. So just keeping an open mind around all of that. But this is a great question.
Do you have a version, Dr. Watanabe, that you would like to share?
Yes, if I may, before I, answer the question you have posed, I would also like to remind us as practitioners that sometimes we ourselves have to protect ourselves and self-care. Because when you are constantly being exposed, sometimes, I find that I personally am running on an empty tank, and you're expected to, empathize. And I, had a question during the break on that. And we just have to be truthful to ourselves that we also need refueling. And, because a lot of this is heavy. And, it's not that we can leave behind in our consulting rooms. Sometimes we go home and we're so traumatized by what we have heard or seen that, we find it difficult to leave, in our practices. So I just wanted to, bring that aspect to the fore. A lot of the cultural nuances that I referred to, I'm speaking of the vast majority, almost 70% of rural poor. It's all right for those who live in the cities and can access the sorts of care that we are talking about, for most of this week. But there are myths, there is disinformation, there is misinformation. And therefore, when we are seeing some of these patients, and it's easier to ask if they have heard about it happening to a third party. They will then feel more comfortable about saying, that happened to me. Language is a huge barrier. So, working in an environment where communication is the first thing. So I'll give Nigeria as an example again, where we have about 500 languages. So, as a practitioner, you have to be able to communicate. Lastly, in this context, I'll talk about who is present. One of the first barriers comes from the home. A woman wanting to seek health care has to get permission from her husband or from her mother-in-law who lives in the same hut or homestead. And so she needs urgent care, even sometimes for women in pregnancy. But here we're talking of, sexual health and menopause, and she has to first get that permission. And in even going to access health care, she might be accompanied by her abuser. And that in itself means that she cannot share in a confidential manner what she's going through. So she might use a flanking approach as, she's talking to you.
It's such a good reminder, too, that, obviously we may be traumatized. And so this can be even more difficult for us. And with the universal trauma-informed care, you have to treat everyone as though that obviously it could be part of their experience. And one of our audience members asked, what are the best strategies you would use to support emotional regulation during an assessment? And I'm sure that could be both yours and the patient's, but what would you say about that?
Shall I start? So there are a couple of different things. One is, in an ideal world, you'll have had a chance to say, are there any experiences that make it helpful as you get through appointments? Things that, help you. So sometimes, especially if you're going to be doing some sort of procedure, or you're going to be asking a sensitive history, it's really helpful to ask that at the front end, so you know some of the things that you're going to go back to. Basic grounding techniques and basic breathing techniques remain very useful. Very simple, very useful. And so there's even 3 deep breaths can help somebody regroup. Box breathing is another, that sort of inhale 4, hold 4, exhale 4, hold 4. It's an easy visual. There are all sorts of other ones that are also good, but that's a really straightforward one. And sometimes just doing those 3 breaths with the patient is something that helps us both, right? Everybody gets to kind of regroup. So that's one thing. The other is, there's a whole series of other techniques. And one is, can you tell me 3 things that you see? Can you tell me 3 things that you feel? Really grounding people into the current sort of present moment. Some people will have a little squishy thing that they want to hold and make sure that they can hold that. But I really kind of coming back to some of those, reminding them that they can stop, right? You're trying to get the locus of control back, helping them regroup. Some people, piece of ice or something really cold, you want to kind of activate the parasympathetic nervous system a little bit. But that's some strategies.
That's really helpful. And then I know, at least what my understanding is, there's a wisdom and recommendation that sometimes we shouldn't ask, that people will tell us when they're ready. So you don't agree. Anyway, But then I feel like we're not going to, so how would you recommend that? Like the way to broach it in a way that's not going to traumatize people. And some people do say that people will tell you when they're ready. So what's a good just framing question, like a really quick one, or how do you approach that? And then we get conflicting advice.
Again, giving a nuanced piece here. So in my experience, I've worked with young girls and women who have been rescued in conflict, and they're in internally displaced persons camps, and what I call the power of the pack. So it's more like what you would call group therapy. So a young girl has been abducted. She's, a widow before she's the age of 12 because she was married at the age of 10. She's lived in the forest with her Boko Haram captors, and she's now rescued. But finding people in the internally displaced persons camp like herself is such that you can, discuss in a group as to how did you cope or how didn't you cope. So you will see that there's an international alert report on, that was, termed, they called our children, they stigmatized our children, where these young girls had babies in the forest, and you would think that their families would be happy because they have been rescued by the Nigerian army. But because they have had children for Boko Haram, then their children are stigmatized. But when you have them in that power of the flock and they're together and they're all experiencing it, they can then share. I have had less experience with women who are going through the menopause, but definitely, issues around sexual health, around, having children having children. And the correct name is, they called them bad blood. That's the correct name, bad blood. So where their children were called bad blood. And they were able to cope with that better as a group.
I think in other settings, to answer this question about whether to bring it up explicitly or not, I think it's very much in the framing, and again, in what are you going to do with this information, right? So if you're able to sort of frame it that I'm going to ask you a series of questions that will help me care for you better. I ask all my patients who are potentially affected by menopause about their sexual health. Experiences in the past, as well as more recently, can impact that, like, any unwanted sexual contact or other experiences. Would it be helpful to talk about that? Is that something you're comfortable sort of sharing? Or if not now, you should be comfortable in the future. Again, a little bit of this kind of creating space. One of the reasons people will not disclose is because they're afraid that the person who they're going to disclose to can't handle it or won't respond in a way that they feel safe and okay and not invalidated. So the more that you are creating a space where they feel like if they told you, you wouldn't freak or go, oh my God, or we need to get you out of there, or these kind of reactive responses. If they can sort of trust that this is something that you can probably tolerate and be helpful with and hold, that's where you're going to start getting some of these disclosures. So it's, I think understanding this as a potential process is quite useful. But putting those words out there to your question is useful because you're normalizing words like sexual health and unwanted sexual contact, like but really not putting people on the spot so that they don't feel like if they don't answer completely or honestly that you're going to think they're a bad patient and not want to schedule them for follow-up. Or they won't want to come back because they know that they didn't tell you the truth the first time. And by leaving it open, you've left the door open for them to come back.
So two really great questions here. One is, what if someone has, you're speaking English and they have limited English and you're using an interpreter, but they prefer to use a family member or husband as their interpreter? Is there any way around that, or do you ever just insist on having a neutral interpreter?
Yes, it's obviously helpful to have an interpreter because of, several diverse languages, but you have to, one, look at the body language and ask more probing questions in order to identify if the chaperone, and in quotes, is a friend or a foe. So if you have the woman come into your clinic and she is with the mother-in-law who is encouraging her son to beat you because the meals are not ready on time, then you're less likely. So it's getting that element of trust right. It's usually better to get a third party, so you can get a community health extension worker to be the interpreter as opposed to the family member.
Mm-hmm. So, and then what about when you do ask, and I know I can think back over the years, multiple patients, and I don't think I did anything wrong, but they don't come back. And maybe it's just they felt unsafe. Different people, I can think of, I had a woman who didn't want a pap smear, and of course I didn't force her, but then she came back, she got herself all brave. We did the pap, it went really well, no discomfort, but then she never came back. Or people like Fiona Carver that have bulimia, or just a number of things, and I think it traumatized them, and you don't see them again. And so a question here is, again, how would you respond? Also, if the patient gets angry, is there a way to reset the visit? What's a good way to respond if your screening question is met with discomfort from the patient?
Sometimes just naming, I can see you're upset. I'm so sorry if my question upset you. Is there a different way that I should ask it, or would you rather just kind of move on to some other questions? I think, sometimes really recognizing that between intent and impact, there can be this gap that you may not have foreseen, but it happens. And there also needs to be a little bit of self-compassion in that. You're sort of coming at it from a good place. And I think also relaying authenticity can be very powerful when somebody sort of sees, and you're not apologizing for the question, but you're apologizing that it landed in a way that was upsetting. And can you help me reframe or regroup so that we can continue, is something that actually there's a lot of room for repair. And, I think we say a lot that sometimes when you're working with someone who has a lot of trauma, things that aren't personal feel personal. And you're the sort of person who's going to be the sort of recipient of whatever that's coming out. And, sometimes it's sort of like recognizing the anger. Sometimes it's also recognizing maybe this is anxiety. Maybe this is distress. Maybe this is a way of them ending the visit before you actually ask them to do something that they're not comfortable with, because it's easier to be angry than to be sad. This is better than the shame of saying I'm not comfortable doing something or I can't see it through. And so recognizing that could be a marker of many different things can also create a bit of space for dialogue where there's room for dialogue, and then also some self-compassion if maybe this isn't where they were that day.
Okay, so what is a good first response if the patient says yes or gives an indication that there is a trauma? These are just some possibilities. Thank you for trusting me with that. That must have been very difficult. What you share will help me give you better care. These are just a couple of examples, but what do you have a particular thing, a phrase that you like to use, or what advice would you have for people who aren't very familiar with this?
My preference is, I'm really sorry that happened to you, and I appreciate your sharing that with me.
Good.
I'll say one thing about the must have been difficult, I think is a complicated, just the frame in general can sometimes get us into trouble. because we don't know what it was for those folks, right? And the things that we might think were really difficult were not difficult for them, and the things that we didn't think were. And so I think appreciating that you shared that, and again, it's that meaning piece, right? I want to make sure we take that into account as we plan the rest of the visit. So you've sort of, you've recognized it, you've appreciated it, and you're making it a kind of, you're grounding them in, you're really modeling that information can help make something a little bit better.
So can you repeat your phrase one more time that you like? It sounded so good.
Oh, say what I said?
Just what was
I'm
the
so sorry
phrase?
that happened to you, and I appreciate your sharing it.
Okay.
I really want to make sure that we plan our visit in a way that's going to be supportive and takes that into account.
That's great. Any, Dr. Watanabe, anything
For me,
different?
In our context, it would be, what you've shared, has helped me to give you better care and would give others in your situation better care, because, what speaks loud and clear is being able to say that by sharing what's happening to you, I can, give you the best amongst the options that are available.
So,
I'm gonna say something else, which is sometimes when people do disclose, there can be tears behind that. And it can sometimes really be helpful to say something like, it takes so much strength to be that vulnerable, or it's really brave to be that vulnerable. Just kind of recognizing both pieces there can help somebody feel held in that response.
that's great. It makes me feel safe that it feels very warm and really wonderful. I think that phraseology. What is the minimum safe response for a patient in both of your clinical settings if there's a reveal that someone has some ongoing issues and is very distressed by it? So, Dr. Levy-Carrick, we have generally social workers and things we can refer to, or?
Yeah, I mean, it's super context specific and resource specific. I think where there's a social worker available or any kind of mental health resource, direct mental health resource available, that's like a good thing to advocate for, depending on your practice, that there is someone who's trained to help be supportive in this. But I would also say you don't have to be a therapist to be therapeutic. I think sort of recognizing that listening and holding that probably is part of the intervention. And then the sort of safety part, again, there's an imminent danger sort of reporting piece that we have to just be attentive to. Is there a child at risk? Is there a vulnerable adult you've just heard about? And if there isn't, right, you can take a step back. Again, we want to see someone's resilience here as well and understand what's going on. I would say, again, in the US, 988 is there for everyone. It's 24/7. That is kind of a minimum. We're very fortunate to have what's called Passageways, which is it's a program for people who have a history of interpersonal violence. So these are counselors who are trained to work with that set of patients in particular, as opposed to kind of a more general mental health expert. And again, I do think just screening for suicidality is helpful, in part because, of course, we want to know if it's imminent, but also because we always want to reinforce asking somebody is not going to make them suddenly suicidal. If anything, it's just going to reveal, right? And by asking, you're also normalizing that this is a space where we want to know and where we can do things to help. And so those are sort of, if you want for yourself to know that you've kind of covered the bases, you really want to do some of that basic risk assessment. We can talk more about sort of broader risk assessment. You want to make sure there's, clear for firearms, find out if they've done anything to harm themselves in the past. Like that's where the context ends up helping a lot. The other piece is is this acute or is this distant, right? Because if somebody had, and this is, I think, in the patients with menopause, you saw a lot of the violence happens early. And they may be deeply distressed, and there may be a lot that needs to be unpacked in the context of your visit, but it's not imminent danger. This is sort of dealing with the sequelae thereof, and unpacking those two can also be very helpful. I get referrals sometimes, and like the patients, in an IPV situation. And when you get a good history, it's been 20 years. It's unresolved, it's very conflictual, but it's not acute. And that helps a lot in terms of deciding how much or how little needs to happen in the moment.
Okay.
Thank you, Dr.
Anything to add?
If I may, bring some nuance again to that it's dependent on access, it's dependent on affordability, the infrastructure, as well as a neat referral pathway. So being able to call on, multi-sectoral response mechanisms where they exist, and in community settings where they do not exist, to ensure that, we can use cultural gatekeepers who are safe to approach. So it could be a traditional leader, it could be a religious leader. But, permit me to share that, whilst I'm bringing the context that's mostly outside, that is not US-centric, in the course of doing some research for this session, I came across a report that is in the public domain of a lady who was actually genitally mutilated here in the United States. And this was, quite some time ago, where, and she's online as Dr. Renee Bergstrom from Dakota, where she has started an advocacy group. As a child, she was accused of masturbation and was taken right there in Dakota, and her clitoris, part of her clitoris was removed. And, to quote it, she said, "It felt like my body was punishing me all over again," end of quote, as she went through menopause with, it was earlier menopause, increased PTSD, more painful vaginal dryness. So again, just to show you that, we usually look at some of these contexts in what we might call a developing or less developed country. And yet, this is, even though it's historical, that, other developed countries have passed through, such issues as well. In the context of menopause and early menopause, also coming across hysterectomies that are performed by sugar farmers in India. Why do they do this? Young women who are not yet menopausal, removing their uteruses to ensure that they do not have their monthly periods, in order not to lose out on work hours, either due to dysmenorrhea or period pain. So when you have situations like that, it's not a one-size-fits-all. When you see a young lady in that situation, you need to be able to show the appropriate empathy and ensure the appropriate referral in order to assist her in a way that she's also not losing out economically. She has opted to go for a hysterectomy so that she can work longer hours. So it's a delicate dance.
Thank you. I feel really terrible about this because we're almost out of time. And this is so important and such an important topic. So thank you both for being on our panel. Let's just do a couple really quick points, though, just to finish. One is sensitive exams, and Dr. Levy Carrick said she's a psychiatrist, and so, but let me just say, as a doctor myself who does physical exams and gynecologic exams, we did hear already about the principles of trauma-informed care. I'm sure a lot of you are familiar, and it's also very intuitive. I think as a physician, we've been taught how to respect patient privacy, but sometimes we need to level up a little bit in this regard and be more sensitive. And so just some kind of universal recommendations, obviously, to have, I know some of our clinics have a chaperone for every exam, with male or anyone. That's one thing you can do in a population that has a lot of trauma. And then obviously consent. Never push someone to do any parts of the exam they don't want to. Never have them undress in any way they don't need to. If it's an emergency, then you can discuss that more urgently. I make my patients a no pain promise. In terms of the pelvic exams, for example, when I go to do the pelvic exam, almost on any woman, I'll just use one finger first with the glove and some lubrication. If that's uncomfortable, if I can see her tensing up, then I just stop. And, we can readdress it later if it's not an emergency. So those are some things. And one of our participants suggested as well that she has a sign with people that she has them hold the end of the blanket, and she tells the patient, if you want to stop, you can just drop the blanket. I'll know that you want to finish. And I think that's really a nice thing to have some kind of signal with the patient that if they want it to finish. And sometimes I just tell them verbally, we'll stop any time. Are you okay? And just make sure they know that. And I tell them in the beginning. And I'm specifically speaking about a pelvic exam. But, anytime you want to stop, we don't need to do this.
I can add a couple things. I think that's a great one. One is also positioning the patient up so that they can see you. Lying flat leaves people feeling incredibly vulnerable in almost every other situation, and certainly in the pelvic exam. So that positional piece is really important. And the other thing is, even one thing before, if there is any chance to see the patient while they're dressed before the exam, that makes a really big difference in the patient sort of knowing that you've sort of seen them as a person before you're doing that exam. And the last thing is just, again, that ask if they want to know each step of the way or be distracted is another relevant one for all of these procedures.
And if I may, please, just to remind us that, just like that last question, the fact that you have shared with me means that I can help you better and help others better. It's always nice to have that feedback loop to the patient so that they know that by sharing or by coming to you that they have contributed to the menu of options that others in that position can have. There's many a time we are taking, but there isn't that mutual, mutually beneficial way of either extracting data or providing health care, making sure that patient engagement is part of what we are doing. Thank you.
Thank you. Yes, and I'll say, in my practice, I do see the person dressed first, unless they're a longtime patient, and so I do practice what was suggested for that as well with all my patients, really. So let's just move quickly to language, what to put in the chart. We already said now we know everyone can see their charts, at least here, and they see it whether we like it or not, and they see their test results before we see them. But they can read every word that we say, so we need to be sensitive. And these were just some suggestions, not old-fashioned would be to say the patient refused, to be careful about that, or to call someone non-compliant, or, to say, oh, they deny alcohol abuse. There's certain words that we can use. But what would you two give us just a real quick, maybe one each, of a language we should avoid? And is it okay to what would you put in the problem list or in the chart? If abuse is an issue, should you just not mention it at all? Or if you don't have a locked chart?
I will, so I guess two things. One is, I think these are great examples. The other, we could pick a whole other set around substance use and cessation efforts. The way that we document also matters because it's the way that we think about people. And so this isn't just like a medical legal thing. This is helping people to think about people differently. And if a patient declined an exam, it's different than that they're being, defiant. It's sort of recognizing their humanity and their autonomy. So that's very useful. With the problem list, I will always ask a patient, I could just put psychosocial stressors. Do you want to leave it at that? Or do you want to sort of mention something more specific? In other clinics where there might be more specific documentation and physical exam, thinking in terms of where that hits on the physical exam problem list could be a way of doing it. But in the psychiatric domain, patients really appreciate it just saying as like a psychosocial stressor, very general marker of the fact that there's something to go back to.
Mm-hmm. I would like to maybe pivot from what the patient should do, bless you, to what the provider should do. The reason I say that is that when we look at the high maternal mortality rates, one of the things that has been researched is lack of conducive either, consulting clinics or infrastructure or hospitals. And I have one example where we, as the Medical Women's Association of Nigeria, several years ago, we set up a screening center for breast and cervical cancers, and we had this massive sign outside saying, breast and cervical screening. But because cancer at the time and still is highly stigmatized by families, people were reluctant to come. Once we changed the sign to Well Woman Center, then women were more likely to walk in to get screened. But sometimes, rather than say that the patient was facing barriers to treatment, to say that there can be improvement in the services being offered, where, the consulting room and the reception room, there's just a little curtain that doesn't provide privacy. So in what way can we provide a better service to somebody walking into the facility?
All right, so unfortunately we're out of time, but there is one question that 5 people upvoted, and that was just maybe Dr. Levy-Carrick. There's a significant amount of talk about psychedelic-assisted intervention in PTSD. Can you just tell us quickly if that's effective? And obviously we won't have time we won't be able to do the topic justice, but what would you say about that?
Yeah, I could have added that to the list. I mean, there is a growing body of literature that it does have a role to play. Importantly, it comes alongside therapy. It's not, and so I do think that, yes, it has a role to play. It needs to be done in a very sort of thoughtful, careful setting where it's part of a comprehensive treatment.
All right, well, thank you so much, Dr. Wadnomi and Dr. Levy-Carrick, and